So our next presenter is Dr. Keith Goss. He is the Division Chief of Podiatry at the Tuba City Regional Healthcare Center in Tuba City, Arizona, and is also the president of the IHS Podiatry Council and professor at Midwestern University School of Podiatry. He specializes in rear foot reconstruction and limb salvage, particularly in the diabetic population, and he will now be discussing how he treats Charcot foot using the DynaNail.
Hello, everybody. Thanks for your attention tonight. I want to thank Dr. Shibuya for a great presentation as well. Tonight, I have the privilege of your attention again to talk about one of the most exciting and scary pathologies we deal with in the foot and ankle, and that's the Charcot ankle. And, you know, there's probably nothing that's going to be more scary that comes in your door of practice than the Charcot ankle arthropathy. And I'm hoping that after this 10-minute presentation, might be a little bit more, that you'll have the confidence, the skills, maybe some new ideas to get your patients and you the success you want in your salvage surgery. So without any further ado, I'm going to move on. So no better way to start than with a failure of mine. This is a 69-year-old female, comes in with an ankle fracture. You go to the emergency room, they say, oh, it's a low-energy ankle sprain, and they call it a bimalleolar fracture. But you look at the fracture pattern, and you're really not convinced that this is a normal fracture. And you take a little look at the history, and you see a high HbA1c, like Dr. Shibuya was talking about. And you see a pretty poor renal status, chronic kidney disease level of 3. And in my more amateur days, I said, you know what, we're just going to go ahead and fix it. You get a wonderful ORF, get this wonderful x-ray. You can't wait to take a picture of it, maybe send a picture of your mom's, put it in the refrigerator. And you feel pretty good, 4 months post-op, looking great. And then, oh my God, at 1.5 years later, look at this patient. It's a disaster. She's swollen. She's painful. How did this happen? And so what do? We reach for our rod of salvation. We get our Medshape nail, and then we're so pleased with ourselves. We finally got our fusion. Now, 3.5 years after the day of injury, we've got a nice x-ray. She's pain-free. But at what price? We have to start thinking about what is the price our patients are paying for the salvages that we want for them, for the x-rays we want to look at. And I just want to introduce at the beginning of a presentation something called the 5 Ds of salvage surgery. These are the things that we do to our patients. We commit them to. We commit them sometimes to disease. We make them disabled. We make them destitute, divorced, and then sometimes deceased. So there's a great responsibility with for us not only to fight for a salvage, but to get it done right the first time. And so we have to ask ourselves, could this have been predicted? Could we have looked back at that patient and said, hey, we could have done something better that would have worked the first time? And if so, could we have selected a different surgical course? And if there is a different surgical course, is there a one-and-done procedure that's going to maximize safety, efficiency, and cost? So let's put those ideas into our head, those questions. Let's take a look at a second case. This case was sent to me from the other side of the reservation. Oh, it was just a stubborn to heal medial malleolar fracture, I heard. Well, this was revised a couple of times, a typical fluoro screw fixation, fail. And of course, what the first thing a lot of surgeons will do is blame the patient. Oh, they're an alcoholic. Oh, they're non-compliant. So they call it a non-union. They blame the other surgeon, call it hardware failure. But we know there's something else going on because we look at that history again, and we see a high HbA1c, poor renal status. Does this mean the patient can't heal? No, but we're going to have to reach for something like dynamic compression, or the DynaNail, to basically give and impart this patient with the compression over time requisite to create a fusion and a stable result for this patient. The patient did fantastic, community ambulator, return to regional function. So we're seeing a pattern develop in these patients. Now here's probably the worst case of these medial tibial columnar blowouts. Now, this patient has obviously been neglected. I'm sure at some point it was a medial malleolar fracture. I had the great privilege of seeing this patient 4.5 months after the day of injury. 3 surgeons said, the only thing that's going to work for this patient is a below-knee amputation. And so we figured, well, we're going to try to do something more for this patient. Once again, let's take a look at their health. CKD of 3, HbA1c greater than 10. Well, we get a solid fusion, and we get this patient walking. I think it's important when people give you a presentation to show you an actual functional result, show you a happy ankle, because it's important to know that salvage surgery does actually bring people back to function. And just give you a picture of how this patient is walking. This patient does not need a brace. This patient doesn't need anything special. He's just walking with a cane. So just to let you know, the DynaNail is a phenomenal device for healing some of the worst the worst ankle arthropathy, Charcot ankle arthropathy cases you're going to see. Well, let's take a new turn. Let's look at the patients that are absolutely, we've doomed to failure. Let's take the patients like this. This patient, believe it or not, was referred to me for having gout. Of course, you walk into the room and the foot is completely immediately inverted to tibia. You know that this patient has Charcot. And so you get an x-ray like this. Now you've got a patient that's on dialysis, been on dialysis for longer than they can remember, 5 or 6 years. And so what do we know about this patient? A lot of people would say this patient's unsalvageable. But what do we know? What are the healing rates of ORF or fusion in end-stage renal? Well, they approach 0. We know that many times ORF attempts and fusion attempts in these patients with horrible renal disease are basically staged amputations. And the complication rates in open surgery and end-stage renal, as Dr. Shibuya said, they approach 100%. So now you're thinking, okay, there's nothing we can do to intervene on this patient. Can you brace them? But by definition, all Charcot ankle is unstable and unbraceable. So does this lead inexorably to amputation? Well, there's some things we have to think about if we're going to consider amputation. The perioperative mortality for DKA is about 25 to 50%. This demographic is so fragile that a balloning amputation might save them from dying from the infection itself or for the deformity that resulted in ultimately an infection, but we may put them away sooner. The percent of patients returning to full function, this demographic, none of these people are going to get back to full function in prosthesis. And does a BKA shorten someone's life? Yes. So this is heartbreaking. We see we can either do a staged amputation with ORF or fusion, or we can get to the amputation. In either event, we're shortening their life. But perhaps there's a middle path. Like Buddha said, there's the middle path, and the middle path is always right. So we developed the concept that maybe fusion is not a value. Maybe we don't need an incision, but maybe we can still deploy Charcot technology. Maybe we can still use a DynaNail. So we started doing these percutaneously. We would do these under popliteal blocks, minimal sedation, about 37 minutes the average surgery. And these patients universally are walking 8 weeks in a CAM boot and then get out, put them in a custom molded Arizona brace. We've got a long series that are doing very, very well. So then let's take a look at this patient, 6 months out, ambulating very well. And finally, here's one of the worst patients that you could possibly imagine. You have a severe trimal. So you go to the emergency room, you realize this is more than a trimalleolar fracture. The patient has a renal transplant. They were on dialysis for 10 years. They've got poor pulses, they've got osteopenia, they're on chronic steroids, anti-rejection medicines, and they're narcotic dependent and chronic regional pain syndrome. So I know most of the people in the audience are saying, oh, well, obviously you're going to want to amputate this patient. But this patient is a community ambulator. This patient is very, very active. The patient deserves an opportunity. And the fracture actually doesn't look that ominous, but the past medical history is clearly very ominous. So what did we do? We tried doing this percutaneous technique. In fact, this is our very first patient. And how did she do? Well, to let you know, this is our longest percutaneous follow-up. Believe it or not, this patient is approaching 3 years post-op. This is her last x-ray. She is wearing flats from Walmart. This lady cannot understand why we keep telling her to come back to our clinic to get checked up. She says she's fine. She thinks we're crazy. And so this has been a very successful procedure for her and for many others. So I guess the question is going to be, who needs percutaneous nailing? And so we need a simple classification system for all of us that basically adheres to the basic truth that there are some people that can fuse and heal their incisions, and then there are some people that simply can't fuse and heal their incisions. But we can almost identify these two different patients in the doorway without doing too much. So we have to agree that there's a spectrum of healing capacity for ankle Charcot. We know that somewhere in the middle, people transition over to a point where open surgery and fusion is not going to work for them. And so we have to think about the word Charcot. Now, we kind of had the shock and awe phase of the presentation with a lot of cases. I kind of want to wax philosophical here for a minute. The word Charcot does not help us in any way. In fact, if you're going to gather anything from this presentation, from my opinion, my wisdom, I think Charcot is at best a post-mortem term. The term we apply to failure. It means we missed something, we didn't diagnose something, or we're treating something late. It's almost like an intellectual flaw. It's a failure on our part to intervene. And sometimes at its worst, it's like a moral failure because we're going to wait to call something a Charcot before we start deploying our Charcot tools to save these people. We're not allowing ourselves to see the people who are eligible for Charcot surgery until we finally let them undergo the late stages, when we can call it Charcot. They have segmental bone loss, deformity, infection. So the word Charcot sort of disables, this nomenclature disables us from being able to see probably the stage 1, stage 2s, and not until it's in full collapse are we able to call something a Charcot and then intervene too late. It's almost like some people won't deal with a non-union until it's 9 months and then put a bone stimulator on. When you can actually see a non-union developing, I believe, in about 4 weeks. So with this being true, I want to introduce a concept. Maybe we change our nomenclature. Just as much as I cannot stand classification systems that don't guide treatment, I don't think we're benefiting ourselves of the nomenclature that doesn't guide us toward a proper classification system. So I call these actually leafro fractures, because all the fractures you saw are lower extremity insufficiency fractures, they're pathologic fractures from people with advanced renal disease over a long period of time. So I'm going to invite you to think about these Charcot fractures, let's call them leafro fractures, as having ultimate causes and proximate causes. The ultimate cause is going to be crappy bone. It's going to be bone that has been leached over time of its value and its strength and its support. And basically, that is going to be a function of the forces applied to it, which are going to be the impact. You hear someone drop a pickle jar on their foot, or you have a patient that's morbidly obese. That's also a force applied. And we know equinus is also an attendant force. So just for the sake of discussion, we're going to make a brief mathematical model that includes everything we need to know and nothing we don't need to know. There's nothing in this model that indicates about the amount of blood flow, the neural status. What we know is if we have poor bone, and basically we have time as a leaching factor for bone, and we make that as a function of torque, where torque is the length of the foot times the force, there's a combination of weight and impact in the equinus angle. Those are all the components, the critical exponents. Those are causation. And I would like to say that vascular status and neural status are correlative, yet not causative. And if we know this, then we know who's at risk for a leafro fracture or a Charcot fracture, and we can identify it early and then treat it. So let's take that back to our spectrum, and let's just say, for simplicity's sake, we've got type 1s. They're going to have low leafro scores. They're going to have bone that hasn't leached its value and its strength out, and they've had lower trauma. And the high leafro scores are going to be people that generally have had high impact trauma or have just incredibly poor bone. And so basically the type 1s are going to be open fusion with compression nail, and the type 2s obviously going to be treated percutaneously with a compression IM nail. So having used this, we then reapply it back. We'll just look at one last patient. This patient was just sent to me recently with a bimalleolar fracture, uncontrolled diabetes, dialysis time 7 years. The patient is blind. All this person wants to do is be able to get out of bed, go to the television, the couch, and the bathroom. And a balloon amputation is not going to help her do that. Plates and screws are not going to work on this patient. We've learned that. This patient has horrible skin. So what do? We do a percutaneous nailing. And she has done wonderfully. She's ambulating. She's doing everything she wants. In a race in her life, this will provide her enough stability. This will render this insufficient bone, this insufficiency fracture, sufficient, like putting rebar into the bone. Yes, she might not be fused, but she will be stable for the rest of her natural life. So our research results, very briefly, we have 20 cases using DynaNail for this leafro protocol, up to a 2+ year follow-up. We've had 2 amputations from infection. One was for concomitant midfoot Charcot and had nothing to do relating to the rear foot nail. And the second one actually refused treatment for an infection of the rear foot. So we have a 90% limb salvage rate, and that has come from being able to differentiate these 2 different people. And these have all returned to the original level of function. So, in summary of my presentation, compression IM nailing is successful in all patients. There's no patient out there with Charcot ankle who is ineligible almost for a DynaNail. The only thing that matters is how we're going to apply it. And finally, or second to the last point, is leafro allows us to quickly diagnose, classify, and treat with the most basic information. All we need to know is their renal status, BMI, basically their weight, and the amount of energy applied at the point of index. And percutaneous nailing is not just limb salvage, it's the middle path. It's actually a life salvage technique. So that is my presentation. I hope you all enjoyed it.